Here we are again on a Sunday morning talking about a return to healing, Andy Lazris and Alan Roth. And today we're going to tackle one of the more important barometers of our healthcare system and what really determines the direction it's gone and its dysfunctionality, and that's medical school. Alan and I obviously went a long time ago, and we have children going now. Alan teaches medical school. I've done a lot of research on it and written about it. And Alan, I don't think medical school is truly a Flexner creation. It hasn't changed much. I spoke with someone who runs the Johns Hopkins Medical School, is friends of a friend, and he sent me articles saying that his medical school is completely reformed and no longer in the Flexnerian mold, and yet they do the same thing. And what happens when people go through medical school, they inevitably, as my kids did, and your son's likely going to do, say they have to be specialists. That's just who teaches them. That's the nature of the school. There's no way they will consider primary care. It becomes, and even my daughter yesterday, who's doing an internal medicine rotation, and she's not going to go into that field, says, Dad, all they talk about is just numbers. They don't even look at the patient. They just numbers, numbers, numbers. That's all they do. It's so glad I'm not going into this field. So you live with this all the time, Alan.
Yeah. So let me just give a little background for people who don't know how it's set up. The current medical education system is pretty much the same as it was more than 100 years ago, and how we talk about in our book. So you pretty much graduate high school and you take SAT exams. So you got to do great on the SAT exams to get into a really great college. Okay. Another multiple choice question we talk about. Then you get into a great college, and then you need to do courses that really have nothing to do with being a doctor most of the time. And now you start applying to medical school, where you need great courses in what's called, the MCATs, the Medical College Admission Test. Another multiple choice. So if you're good at, clicking the boxes there, and we continue to click the boxes, you do really great. And then from there, you go into residency training, which is called postgraduate education, which is controlled by the Accreditation Council of Graduate Medical Education, which creates more rules of box clicking and numbers of what you need to get through. And there's primary care residencies like family medicine and internal medicine. And then there's the specialties like surgery and interventional neurology and plastic surgery and all of those things. And that training could be anywhere from, 3 to even 8 or 9 years before someone finishes and starts working their life. But going through the whole point, it's about numbers, numbers, numbers the whole time. So I'll give one quick story about, my affiliations in my residency in New York. We were affiliated with Mount Sinai. That was the first medical school affiliation I formed when I became the program director. Nobody wanted us. We were a safety net hospital. No one really wanted to work with us, care about our patients, nor our learners, who were, many underrepresented minorities. And I decided to go after the big boys in New York and see if they wanted us. And I actually got a meeting. And about 6 months later, I had a contract with the prestigious, world-renowned Mount Sinai College of Medicine. And my residency program was no longer Jamaica Hospital. It was the Mount Sinai School of Medicine at Jamaica Hospital. That affiliation lasted for 10 years. And for 10 years, I put up with hearing the students come into our clinics and saying, oh, I just met with my advisor. He said, if you pick family medicine or primary care internal medicine as a specialty, we're going to be very angry at you. You're going to ruin our record. Okay, because the medical schools are rated on the prestigious residencies they get into in super specialties. And getting into primary care is considered like a yuck thing. It's considered, ooh, that's not good. You have no brains. You're a smart guy. Why would you go into a specialty where you actually have to do everything, then go into one that you do nothing? So what do you think of that?
I totally agree with that being the messaging, and it's beyond even the reputation of the school. You know, where my kids went to a place called Emory, and actually, what the person who was running the residency program was primary care, New Yorker, very liberal, quoted Osler all the time. Truly believed in primary care, and yet nobody goes into primary care. And the reason is every person that teaches them is a specialist, and they are taught that to learn any. So you and I, Alan, we deal with multiple diseases, right? We deal with more things. Like, I feel very comfortable with diseases. That's actually not that difficult, if you ask me. What makes our job difficult and rewarding is we deal with human beings, and that is the crux of it all. Just the idea that we are taking care of people is not an idea that is taught in medical school. So as these people are going through, all they think about is the next test they have to pass. And each test, my kids have gone through so many tests where they have literally spent months studying for these tests, multiple choice tests about irrelevant information that has nothing to do with anything they've actually learned when they talk to patients. It's only stuff they learn when they're reading, going to these lectures and memorizing things. And the first thing they do after they're done with these tests is try to knock all that information out of their brain because they have to open their brain up to the next test. So my son now is on the third boards exam. My daughter just finished the second boards exam. There's many more to come. Just like the MCATs, where you're learning physics, chemistry, biology in the most minute details. There's nothing about this that helps train someone to take care of a person. So as they go through this system, all they see is how difficult it is just to memorize all this stuff. And the thought, they've said, your son said to you what my kids have said to me. He said it's too difficult. And part of the reason too is we're paid less than they are, and we're not paid badly, but we're paid less than they are, and they'd rather be in the 1% of income like cardiologists are, than in the 2 or 3% of income like we are. Again, one of my first doctors, who I work with, patients said, "God, it must be so hard for you in primary care." He said, "Look, I'm doing pretty darn well. I have a nice house. I'm doing well. Don't feel bad for me." But that's kind of what medical students think. They think, you can't go into it. So they go through learning these minutia. They don't learn nutrition. They don't learn exercise. They don't learn that you're supposed to take care of people as whole. They slice the people up into little sections, and everyone who teaches them is a specialist. And when you come out of there, that's what you think reality is. And that's really part of the reason we're having doctors who are non-thinking drones, because they know they have to be on this leash and follow the rules and just do what they are told. And that's what medical school trains them to be like. It wasn't supposed to be like this, Alan. When even Flexner, God knows we demonize this man. He said you're supposed to go to college and get a good liberal arts education and be a thinking person. And he said primary care needs to be the entire backbone of our health education system. But Flexner worked with the corporate entities who felt otherwise. And of course, we know Osler was all about primary care. That's all he talked about. That was what he called a doctor. Everyone else was a technician. And that's how I see it. But medical school sees it very differently. And you come out of those 4 years completely tainted. Even if you went in idealistic, you come out tainted, scared, feeling like, medicine is all about passing tests. And that's what I see from my kids, but also my experience.
So I agree with you 100%. As Osler said, uh, we don't treat diseases. The great physician does not treat a disease. They treat patients who have diseases. And we're treating scientists, okay? When I precept my residents in the clinic or they're in my office, in my faculty practice, this is what I say. They're here. Whatever I'm saying, they're putting into their phone. They actually don't need to memorize anything anymore. They need to learn about the art of medicine because everything is on your phone now with, open evidence and other artificial intelligence tools. You really don't need to know anything about the facts of medicine anymore because it's on your phone. But you need to know what facts are important. So that's one of the big issues. So we're training people to use AI technology and not in the art of medicine. So it's real damage there. The other thing is, we continue not to encourage. So I'm an osteopath, Andy's an MD. I went to a school that when I graduated school, like 90% of my class went into primary care. And now like 20 students out of 400 from my school that I teach at went into primary care. It's falling apart. There will be no primary care if this is what we do. There's the emphasis on being the great doctor, the great clinician is just going away, going away. And getting back to, I didn't give the second part of the story after Mount Sinai in my residency. So for Mount Sinai, I said, okay, it's been 10 years, it's not working. We got to do better. So I said, what's the best school in New York for primary care? And the best school in New York for primary care is where Andy went, to Albert Einstein. And the Albert Einstein College of Medicine, their primary care residencies are known as residencies in social medicine, primary care, internal medicine, and social medicine, and family medicine and social medicine. And they really work hard to do that. So we flipped our affiliation for them. They were very happy to bring us on as another safety net hospital. And what started happening? As it evolved, they got a new CEO. The CEO had an emphasis on quaternary care and procedures and stopped investing in primary care. And their primary care rotation, which used to be 6 weeks long, is now 4 weeks long and not 5 days a week, but 2 days a week. They literally get Einstein students like 8 days in primary care. And their primary care could be different. It's not just with family medicine and primary care internal medicine. It could be almost on anyone that works in an office in ambulatory care. So we're doing nothing in the schools to try and promote what we need, which is a primary care workforce. So I think, we need to talk a little bit about how you and I think that could happen. So what are your ideas on that, Andy?
Well, I mean, one of the biggest ideas is that they actually get exposed to primary care doctors on a regular basis, and not people in the hospital necessarily, but people who are working out in the community. That, again, when Osler started his program at Hopkins, that was completely dismantled by the corporate Flexner report. As soon as a student went to school, a medical student, they were working with community primary care doctors, not only from day one, but through the entire process, all 4 years. And when they saw something interesting or a new disease, they'd go back, and that's when they had classroom work. So it was an integrated process. Primary care was the primary teaching mechanism. And then you go to your class and discuss the disease with people who are in the actual faculty of the medical schools. Some of these are pathologists, radiologists, whatever. They're the ones who are the primary teachers now. They've removed that. And like you say, primary care rotations are the burden. And my kids, if you had to skip something, you skip your clinic. That's what you skipped. Because guess what was more important than clinic? Doing some kind of bogus research project, because you need that for your fellowship. So I can't even tell you the kind of research projects I've seen come out, but they're checking boxes to get into their fellowship. So we have to go the other way. We have to say, hey, we're getting rid of all this multiple choice testing. You're right. It's out there. The information's available. The key thing that students have to learn is how to sift through which information is valid and which isn't, which they don't have any training in. All they do is memorize stuff, and most of it's bogus pharmaceutical data that they're memorizing. Secondly, they need a primary care mentor and experience from day one that is a primary part of their training, not just some add-on that they could skip. We don't need, look, how many doctors are doing in-hospital medicine? I mean, most of us are kicked out of in-hospital medicine. I know very few who emphasize in-hospital medicine, yet that is where all the training is. Let's move the training out into the community. Yes, a little bit of hospital, but a little bit of hospital. It would take, so this Hopkins guy who showed me his revolutionary new program, it was the same nonsense, just recycled. The only thing they do is they use an ultrasound machine occasionally to look at people's legs. That's his great innovation. Forget that. Forget the 2 years of sitting in a classroom memorizing stuff, followed by 2 years rotating through hospitals with specialists. That is a silly system. We need 4 years of being a doctor, being an apprentice, and going back and learning the science from what you actually saw through your eyes and the patients you're experiencing, because you need to see the whole patient and then put the science in. That's what we need. It would really be very easy to do, Alan. But as you say, from your Einstein experience, the way our reimbursement is to hospitals, this isn't making them money. And they make a lot of money off training programs. So
Yeah.
that's the problem.
So for folks that don't know, training programs are actually supported by the federal government through what's called direct and indirect medical payments. Direct payments are hospitals will get a set amount, which is depending upon the state, somewhere between 150 and $250,000 per resident per year to train them. And the second way is through indirect, which is through Medicare and Medicaid funding. So hospitals are not being training programs for altruistic reasons. They're doing it, one, to get money from the federal government. And two, they're getting a cheap labor source because obviously residents are making a lot less. So the reliance on residents in training uh, for the hospital workforce is one of the things that has created that dichotomy of pressure of I got to go do this in the hospital because that's where all the training is. So the hospitals need the residents there. We have a hospital-centric system where most of the expensive care is given, well, 99% of the expensive care is given in the hospital, and the cheap care is in the clinics, and they don't want to fund that anymore. So you're starting to see, and it's coming up now, like if these new cuts come up from the big beautiful bill, you're going to see primary care residency programs close because they're expensive to run, because their residents don't bring in money because they're taking care of patients in the clinic. Okay. Whereas, a third or fourth year surgical resident is doing these big procedures, those things bring the hospital more money. It continues to come back to finance. So, we need to change the way we finance medical education, and we need to change the way we incentivize students to go into it. And I don't know if we'll get to it today about, how to reform primary care, Andy, and maybe pay for some of this medical school stuff, because we're getting closer to the end. But it's just a perverse system. Like it makes no sense, but it continues to propagate the same way because the medical industrial complex, the big hospital systems and the insurance companies and the pharma, they're making a killing on all this and they don't want to see it change. It would be simple to change it, but the big industrial complex doesn't want to see it change because they're making too much money.
And yeah, and we could next week talk about the financing, because when we in our book give a solution to the problem, and by the way, that solution could be encapsulated on half a page. It's extremely simple solution, but it does run up against the fact we're spending $4 trillion. Our solution would probably spend a quarter of that with better results, but all those trillions of dollars are going into people's pockets now, and they do not want to lose that money. So they're going to push back. And the way they push back is saying, "Oh, what do you don't want the best doctors? You don't want the most specialized doctors? You want to just train people in a community?" They're very good at advertising and creating a counter approach to what we're saying. But yeah, it's simple. You go back to Osler again. Osler had it right. Training is about learning to be a doctor, not learning to be a technician. The technician stuff can come later, and there's no reason technicians should be paid more than doctors either. That is an absurdity. So when we talk about the financing, there is a way to pay hospitals and pay medical centers to train primary care doctors. All you do is flip the incentives. You flip how much money goes to primary care and how much goes to technical procedural medicine. Because look, we talked about it before. The person doing the ultrasound, who reads the ultrasound, who's right 99% of the time before the doctor takes a quick look and said, "Yep, that person makes very little money." The doctor who says, "Yep, makes a lot of money." That's insane. Just flip it. Pay the technicians. We could talk too. I've talked to my kids. If you're a cardiologist, You don't have to go to 3 years of internal medicine training and then cardiology. Just do cardiology. You'll finish in 3 years. You'll make the same as everyone else. You're not going to be paid to do all these procedures because the reimbursement system will change. And you go into cardiology because you want to go into cardiology because you don't actually want to take care of the whole patient. And that's fine. Some people don't. But they shouldn't be paid more to do less, and they shouldn't be paid more because our system, right through medical school, encourages them to go through these hoops that are nonsense. They're hoops just to get into these fellowships and residencies. Let's have medical school teach people how to be doctors. Let's teach them how to go through the data and actually understand the data that they're reading, so they're not influenced by pharmaceutical tricks that are everywhere these days and the doctors blindly follow. That's what we do. It's really easy. Like I said, we lay it out in our book. We just need someone brave enough to do this.
Yeah. So
So
it's been proven many times that, the only field of medicine that has truly made a difference in our country and multiple population health studies is primary care. So it's a perverse system. We need to change it. We need to teach people, students, about the art of medicine and get away from everything on your phone and AI and go back to it. But I think it'd be a great talk for us next week, Andy, to talk about the fix. We really haven't done it. And like you said, it's about 5 lines. It's not going to take a much. So.
yep, and that's what we'll talk about. So I will see you next week, Alan.
Take care. Have a good one,
Okay,
everybody.
you too.
Bye bye.